one of the leaders, along with many others, including myself and Dr. Shah, who is here, in helping the guidelines develop internationally. So what I wanted to present was a very brief summary, and these are going to be published in July at the ESHRE meeting, but it is based on a lot of hard work, and I'll go through a little bit more. 44 societies have endorsed the guidelines. We have mainly done through the PCOS Research Center in Australia, as well as ESHRE and ASRM, which are the main organizing bodies, but all of these other institutions. And so we'll just briefly go through things. So we started with the foundation that the Rotterdam diagnosis will be the diagnosis that we will all use worldwide, which I think most of us accept. And you're very well familiar with that. But that's the foundation. And what we wanted to do with the guidelines is look at all of the factors, not just the reproductive factors with which we work every day, but the psychological factors. We spent some time yesterday talking about that, and the metabolic factors, particularly insulin resistance, obesity, diabetes, which are very prevalent. So all of these factors would need to be addressed in the guidelines. We know this disease, as you are all familiar, crosses the lifespan. So it starts in adolescence at a young age, and it goes all the way through menopause. And during that time, a woman's needs change. So the guidelines are not complete yet, but they do try to address all of these issues. So we know that the main concern is that this is very complex to treat women with PCOS. It is a very big burden to the woman and to the society. There is a rising tide of obesity that is making it harder to treat our patients, and many of our patients are not getting treated in a quick enough fashion. We don't think there is good information that is being communicated by general practitioners overall through the world, so we need to get this information out to them as well. So we know that this is a very common condition. Rotterdam criteria, almost 20% in some societies. In the AEPCOS literature, we estimate about 15% of the population is affected. So very high prevalence. So the way the international initiative was built, we took stakeholders, which are the patients, the health professionals, the researchers, consumers, and it was boiled down to the priorities. And then once the priorities were established, there was a knowledge synthesis. So many meta-analyses were systematic reviews contributed to the guidelines. Then there was resource development, and that will come forward once the guidelines are published, and then they will be translated through modules and other activities to help everyone educate. But that will not be the end of the guidelines. The guidelines will be modeled based on the society that the individual lives in and other international awareness campaigns. And then it will be a constant cycle where this will be repeated. So we hope to make this a permanent thing, but it's not static, so it will continue to change. So this is just a list of all the societies that have already endorsed the guideline, including the Federation of Obstetrics and Gynecologic Societies of India, as well as this society, the PCOS Society of India, have already signed off on these guidelines, which will be published soon. So what is evidence-based practice? We all as clinicians wish to practice evidence-based practice. And so it's a lot of cogs in a wheel. We have consumer needs, the reasons they present to us as physicians. We have the evidence that's out there in the journals and the research that we do ourselves. And then we have our own clinical judgment that we have developed over time that makes us a physician that takes all of this into account. So this is the best way to practice. We use the consumer needs, we look at the evidence, and then we use our own judgment to pick and choose the best options for our patients. And so evidence-based practice is not looking at a journal and doing what the journal says. It's taking all of these pieces to make our patients the best, including cost effectiveness. What is least expensive for the patient that will give her the best outcome. So this is just basically the timeline. Nothing to really notice except that this started in January of 2016. So it has been 2.5 years in the making, and the guideline scopes were set at that time. The systematic review ended last year, a year ago, and then the guidelines were written over a 6-month period between July 2017 and December 2017. And in the last 6 months, they have gone out to the societies, and each society has contributed modifications and signed off. So a 2-year process. There were basically 5 groups, and there was a screening group, the prevalence and the management of emotional well-being, lifestyle management, models of care, medical treatment, and screening diagnostic and management of infertility. So each one of these groups consisted of world experts as well as consumers that were brought together and the evidence sifted through. We decided on which topics. There are too many topics for the entire guideline, so only ones that were rated based on judgment of experts and consumers higher than a 4 were included in the guidelines. So most of the decisions were in the critical phase, the ones we thought were of most importance and needed to be addressed currently. And this is just to show you all of the different topics that were discussed, which, some of which we'll talk about shortly. So we wanted to take the work that was already done, the Australian guidelines, the AEPCOS, and that was our benchmark. And then we took systematic reviews that took from those guidelines and expanded them. And then we all agreed basically how to proceed from there with the international experts. The typical evidence search with using all of the normal methods by which we get evidence base. And it was very strict and very stringent. If studies were to be included, they had to reach a significantly reliable bias. So if they were very poor quality studies, they were not included. If they were not randomized studies, that evidence was not included as evidence-based. So there were some studies that we did not include in the analysis because they did not meet those criteria. And the thing that you need to pay attention to as we go through these guidelines is that there are 3 levels. The EBR, evidence-based recommendation, this is the highest level. So evidence-based recommendation is the highest level, and those are ones we are solidly believe are true. The clinical consensus recommendations indicates there was not enough evidence for there to be a clear reason. So the experts in the room decided which were the best based on the available evidence. And the clinical practice points, that is where people contributed, well, this is what it means to me in practice. So they're not necessarily experts, but they are the clinical practice points we thought everyone should need. So you will see these terms, EBR, CCR, and CPP, but they mean different things. Okay, so we'll start one by one. We'll go through diagnosis and screening. And I will say, because this would take forever if we did every single part of the guidelines, it's a 1,000-page document, we can only hit the highlights. But I gave to the organizing committee the original document that has all of the guidelines that should be in the syllabus at some point. So one of the main things that came up, and it came up at our table this morning, is at adolescents, at what point after onset of menarche do irregular cycles indicate that there is a problem? And then what is the most effective measure to diagnose biochemical hyperandrogenism? And the key messages you need to take away from this, that it is 2 years post-menarche that you can consider PCOS, not before then. And if there is someone who presents with problems before then, we consider those at risk for PCOS, not a formal diagnosis, and they may need to be repeated as far as their evaluation as they mature. So here's what the guidelines look like. This was the first one that was 1.1 because we considered this to be the most important. So in those women who are less than 20 years old, 2 years after the onset of menarche with irregular cycles, and that was defined as greater than 35 days or less than 21 days, a diagnosis of PCOS should be considered and assessed according to the guideline. In adolescents who have irregular menstrual cycles, the value and optimal timing of assessment and diagnosis should be discussed with the patient, her family, and looking at all the psychosocial and cultural factors that may come into play. So there will be some patients who you will not diagnose at that point, who may need to wait further because of her social and psychosocial factors. So if you are in adult women with clinically relevant ovulatory dysfunction, you can consider PCOS. But remember that some women with PCOS will have regular cycles, but they will not be ovulatory. So we don't want to exclude those women from the possibility of diagnosis. And then there's the final clinical practice point that was added, that some adolescents, particularly in Western cultures, will start hormonal contraception prior to the ability to diagnose whether she has PCOS. So if someone has this after 12 months, you may wish to start birth control pills, and you can do a baseline assessment, but you cannot make the diagnosis before 2 years. So that's just the important component there. What about measuring androgens? This question comes up a lot. The key message is here, you must look at the patient, assess clinical hyperandrogenism first. Use validated tools that we'll talk about. Look at the patient's distress about her hyperandrogenism. If it bothers her, it's something that's important. There will be ethnic differences. And if you need, then, if you cannot make the diagnosis based on the clinical presentation, and then you would do the biochemical, and that would be bioavailable testosterone, free testosterone, or calculating the index. And it is recommended that you use a high-quality assay, which is the LCMS or extracted RIA. So again, what are the clinical tools that we use? And I've highlighted here, we wish to use the Ferriman-Galway score. Most of us are familiar with that scoring system. We don't all use it in clinical practice, but it is recommended that you do. And this is where it became a little different, I think, throughout the different ethnic cultures. We had to eventually decide that it was more than a range of 4 to 6. We would consider that to be abnormal. There's some debate about this, and I think as time goes on that may change. But that is what the literature tells us should be considered abnormal. And so here is the Ferriman-Galway score with which you're all familiar. But also looking at the data, this really does seem to be much more relevant to certain populations because there are very few hirsutism studies, for instance, in the Indian population. We don't have large population based. So this is primarily based on Asian and United States. So there's probably some large gaps in what we know to be abnormal, and we need more literature. This is how we assess for alopecia. We see this very rarely in the younger patient, but occasionally we do. And certainly in the older patient, we see the way we might describe alopecia. It's very important to sort of look at this so we can manage the progress of the patient. So again, this is evidence-based. You should be using bioavailable testosterone, using a high-quality assay, and you do not need to measure DHES, but it could be considered if you find that other hormones are normal, and they may provide additional information. But we don't want to use poor quality assays, and if you get those, you should repeat them. What about AMH? I know there was a talk on this earlier in this session, and unfortunately at this current state, we do not have enough evidence that AMH can yet be used for the diagnosis of PCOS. So it is not something that we can use as a diagnosis, and I would encourage you not to do it, although measuring it can be helpful for certainly fertility purposes. And there may be, with time, an ability to use this in the future. So this is something to stay aware of. And ultrasound. This is also a very controversial one. We had a lot of response from people about ultrasound. When is it indicated and what is the criteria? So this is what we came up with. Ultrasound should not be used for the diagnosis in adolescents. So we have removed that from the diagnostics tools. So if you're going to diagnose an adolescent woman with PCOS, you use your androgens, clinical or biochemical, and the cycles more than 2 years post-menarche, but not the ultrasound. The threshold will continue to probably be revised as our tools become better. We would recommend only a transvaginal approach because this is the most data. If you cannot do transvaginal, there are different criteria for transabdominal. Using the highest frequency that we recommend, 8 megahertz at this point, we would consider follicle number of greater than or equal to 20 and a volume of greater than or equal to 10 to diagnose PCOM. So you have to look for other cysts, other follicles that are larger, or other abnormalities to make this diagnosis. So this is not necessary to do ultrasound. If you have a woman who is not having periods and she is hirsute and you have ruled her out for other conditions, she does not need an ultrasound to make the diagnosis, although that can be confirmatory to complete her phenotype. And we wanted to recognize strongly that there is ethnic variability. And so you all know your populations and you know the normals as you see them through. Whereas in the United States, we have so many different ethnic bases. We have many different geographic variations as well. So it's important that we modify these criteria as we get to know more about those individual populations. So we know that cardiovascular disease may be a part of this constellation of syndrome. What is the most effective tool to do assessments? So we would suggest that everyone have their weight followed, counseled about excess weight at every visit. We should measure their waist circumference ideally and follow WHO guidelines as to what is normal. consideration given for Asian and high-risk ethnicities and adolescents specific ranges. So there are some populations that will be less, lower BMI but higher risk. And we should all recognize that there should be a baseline assessment for this. So what does it mean, a baseline assessment? We should have a lipid profile, which is a total cholesterol, low-density lipoprotein cholesterol, high-density lipoprotein, and triglyceride level at the diagnosis. And thereafter, you measure it based on what those baseline parameters are. If they are borderline or high, then they need to be repeated relatively frequency on a yearly basis. If they are normal, and she has normal weight, you may space that out more. We should measure blood pressure on an annual basis. What about type 2 diabetes? As we all know, this is quite high in populations, 5-fold higher in Asia, 4-fold higher in Americas, 3-fold higher in Europe. And so we need to recognize that all women, regardless of their BMI, are at risk. Women who are obese are going to be at much more significant risk. So it is recommended that the glycemic status be assessed at baseline and 1 to 3 years, depending on that individual's risk. And we recommend an oral glucose tolerance test if possible, or if not, a hemoglobin A1C or fasting plasma glucose may be substituted for those. If a woman is planning pregnancy, it is very important to get this at the baseline. So sleep apnea, also I believe you had a talk on this. We recommend screening for sleep apnea, and a simple questionnaire, preferably the Berlin tool, could be applied, and if positive, referral to a specialist. Endometrial cancer, similarly, we should be aware that there is an increased risk, 2 to 6-fold, often premenopausally. But overall, this risk is relatively low, particularly in someone who has been cycling or treated with birth control pills. With respect to obesity, we believe that women with PCOS do have an increased risk of weight gain and obesity, and it is obviously a significant concern. So all women should have weight, height, BMI, and a waist circumference assessed on an annual basis. And ideally, we would want to recommend ways to prevent weight gain in those of us that have patients who are not obese, but they could potentially become so, particularly after adolescence. So that was diagnosis 1. We covered emotional well-being yesterday, so I'm not going to go through that, but there is a whole guideline section on that as well. So I will briefly go over fertility because I know that you talked about this as well. There's quite a bit of evidence in the fertility literature, so there is a bit more evidence-based. But basically, preconceptually, we should, as I said, recommend reviewing all of the risk factors: glucose, weight, blood pressure, smoking. All of the factors that affect a pregnancy should be addressed. With respect to whether you need to do tubal patency, the committees decided that if you have anovulation alone and a normal male factor, you can discuss with the patient whether they need to have tubal factor assessment. It depends on the clinical situation. But if you suspect it, then you should look for it. With respect to ovulation induction, many people will not have on label. In the United States, for instance, letrozole and metformin are not approved for this. However, we still would recommend use of off-labeling and informing the patient that it is off-label, but it can be effective. We would not recommend using these for more than 12 cycles. So if you have a patient going through ovulating 12 times and no pregnancy, you need to look for other things and not continue that. Aromatase inhibitors in the guidelines, because based on evidence, will be recommended as the first-line therapy for ovulation induction over clomiphene. But you can use other agents if that is not available in your situation. Clomiphene citrate is effective. Is metformin effective? These were other questions that we had in the guidelines. And there is clear evidence that clomiphene can be used, very effective. Metformin can be used with no other infertility factors to improve ovulation. But women should be informed that if they just use metformin, it will give a lower rate of success than clomiphene. And if we do use metformin, you might want to add clomiphene if they are not effective. With respect to gonadotropins, these are to be considered second line because of the risks of multiple birth and the cost and the need for monitoring. But in certain circumstances, under economic conditions, you may consider this first line if there is a counseling that there are no other options that would be available to them. So in the final use of gonadotropins, I think you'll have a talk next on laparoscopic ovarian surgery, which we're not going to discuss in the guidelines, but either one can be considered as second-line therapy. Ovarian surgery, as we discussed, could be first-line therapy if you're doing laparoscopy for other reasons in women with PCOS. And the risks should be explained to women considering surgery. And you need to look at costs and expertise and make sure the individual who is operating is aware. Bariatric surgery for fertility is considered experimental. While we do see all of us have patients who do bariatric surgery and they become pregnant spontaneously, there's not yet enough evidence to recommend it specifically for women who wish to become pregnant because the risks in pregnancy have not yet well been defined. And then with respect to IVF and ICSI, IVF could be offered first if you have tubal disease or severe male factor. If you wish to use single embryo transfer, IVF can be effective because women respond with so many oocytes, but again, considering cost and convenience and safety for the patient. If you are going to do ovulation induction IVF, it is recommended that you use the GnRH antagonist protocol. We're not going to go into detail today, but this is part of the evidence base in the literature that this is the preferred protocol over the GnRH agonist long protocol. If you wish to do IVF and controlled ovarian hyperstimulation, you should consider the use of metformin because the evidence suggests that it will improve clinical pregnancy rates and reduce the risk of ovarian hyperstimulation. So that is now recommended in the guidelines. And finally, the medical treatments and the guideline translation. So the last piece of it. Again, one of the fundamental aspects is that lifestyle is critical for all of our patients. So it should be part of our discussion at the very onset, and we should be targeting her primary concerns, the reasons that she comes to us. And remember what our pharmacological therapy options are. So the birth control pill reduces androgens and hair excess. It can be effective contraception. It provides endometrial protection. The low-dose OCP is the best. Again, there's no approval for OCP specifically for PCOS, but it is very effective. And all of the international guidelines, including this one, have recommended it. It is evidence-based. So what about adolescents? This is always a tricky one, and I understood from this morning's discussion that it may be very challenging in the communities that you work in to convince the family that a birth control pill can be effective therapy. But the guidelines do say that based on the evidence, these are all evidence-based, the COCP alone should be considered in adolescents who have a clear diagnosis for management of their androgen excess and their menstrual cycles. It is very effective and it is very safe. You could consider it even in women or adolescents who are at risk, but they are not yet diagnosed. For instance, they have very severe menorrhagia, but they have not been far enough away from their menarche. You can still use it, but remember, you would have to repeat their assessment later. If you're going to choose it, you want to choose a low-dose preparation. We should not use the 35 microgram or higher pills as the first-line therapy. Metformin could be considered if you have metabolic features along with the birth control pill. Again, these are evidence-based. And in adolescents who have elevated BMI, it is considered to be first-line therapy. If you have a woman who has cardiovascular and metabolic risk, again, lifestyle is important and addressing the prevention of weight gain. Lifestyle change, 5% weight loss reduces risk of diabetes by 50 to 60%, and metformin also decreases risk by 50%. So we believe that metformin has a role to relieve symptoms and reduce metabolic risk, and it may help with weight gain. Lots of studies in the non-PCOS population show a very clear reduction in weight when you're given metformin. With respect to lifestyle intervention, it is felt best, it is multi-component. So it needs to have diet, exercise, as well as behavioral intervention. And we should be focusing on healthy behaviors. Healthy eating, regular physical exercise should be recommended to all women. Ultimately, we aim for a goal of 5 to 10% weight loss. Behavioral interventions should be included along with lifestyle interventions, so things like goal setting, self-monitoring, stimulus control, problem solving, assertiveness training, slower eating, reinforcing changes, and relapse prevention to optimize weight management. And dietary interventions, unfortunately, there are no data that tell us one diet is better than another. So I would avoid going to patients and telling them this is the only diet that you can choose. You must work with the patient as to what would work for her. And this is true in the obesity literature as well. So a variety of dietary approaches could be recommended to reduce energy intake. And basically, if we reduce calories, we will reduce weight. I'm not sure what that sound is. Exercise intervention is recommended. We talked about that yesterday. And basically recommending 150 minutes per week. In adolescents, there should be 60 minutes per day. So a bit more about metformin. There is evidence it improves ovulation cycles and reduces glucose, insulin, and blood pressure. It reduces the chances of diabetes. Again, it may prevent weight gain. Side effects are rare, but the gastrointestinal side effects are very common. It's not approved, it's considered off-label, but it is evidence-based. So metformin is effective along with hormonal and clinical features in weight in adolescents and adults. We've covered a little bit of this. So you can add metformin to lifestyle. It could be given to women with adult women. It can be considered useful in adolescent women. Not with the birth control pills, just by itself, along with lifestyle. So metformin has evidence that it is effective all by itself. Inositol, there's only one study that was made the evidence-based, but it did make evidence-based. It is still considered in the guidelines to be experimental therapy, but it is too certain to advocate for it, but I know it's a lot in clinical use, so hopefully we will get more data about how effective inositol is. With respect to hirsutism, this is often the most problematic, at least in my clinic. Patients are very, very concerned about the hirsutism. It affects their body image, their self-esteem, and their quality of life. Cosmetics are really the first line therapy. So laser therapy, removing hair. Medical therapy is not as effective, but the primary therapy is the birth control pill and the anti-androgen. And we want to trial these for 6 months before changing. And if you have hair loss, you often need multiple modalities, and we work with a dermatologist for that. So the presence of, we want to make sure that the women on anti-androgens are using contraception. That's pretty clear. And how do we administer care? We talked about this at the session yesterday. What is the effectiveness compared to usual care? And this is very challenging because many of you mentioned in your clinics it's very challenging in private groups to have the multimodal care. But that is going to be ultimately what we think is the most effective for women with PCOS. So the patient is central to the care and holds the management plan. We have our specialists, our gynecologists, our endocrinologists, our dermatologists. We have the allied health professionals, our nutritionists, our physiologists, our psychologists, and then the general practitioner who will be managing the day-to-day symptoms. So we want to make sure that all of these are available to the patient, ideally in the same setting. So the interdisciplinary care should be offered where appropriate. It's a very, very difficult situation in systems where they don't have all of these abilities to do that. So finally, guidelines are not changing practice. So we can publish 10,000 pages of guidelines. It doesn't matter if nobody does them. So there's a next step to the guidelines, and that will be the translation of these guidelines to your practice. And so all of them are going to be co-created. I know that you here in PCOS Society of India already have modules, and those modules can be modified with the updated guidelines. That gives us very consistent practices amongst all the gynecologists and specialists in India. The idea, of course, is to build across all cultures the ability of health professionals to deliver the same care, whether you're in the United States, India, other parts of Asia, Australia, Europe. We want to have the same care for the women with PCOS. We also want the consumers to have that as well. So this is sort of the cycle that we would hope to. We have formative research that will continue to inform us, inform the consumers, other people as well, and evaluate constantly and change this as we go along, keeping the messages. And we now are going to have, as of July 2nd, links to broad professional societies. There'll be free consumer, free clinician resources that you can click on and download. The PCOS Center for Research Excellence will have as their website. This will be all linked there, and it will be extensively published once it's been released to the public. So hopefully we will be able to also have apps that the patient will have on her phone. We will have ability to constantly update that and get feedback for the patient. So again, this is the website that will be available. If you want to write that down, on July 2nd, this will be the release of the guidelines. They will be disseminated to all societies. I know that Dr. Shah has already looked at moving her modules, the modules for the PCOS Society, that will be in line with this as well to keep all the education purposes. There's other consumer resources as well that are available at the Jean Hales organization.
Thank you. Thank you, Dr. Kathleen.
Sorry. Yes.
Yeah, we can.
Thank you. Thank you.
I know it was a lot to cover, so I appreciate your patience. Okay.